Okay. So that piece of music and the tech on there was meant to attract your attention and say we're about to start. So please, could everybody take their seats with great speed? And there are lots of seats in the front. And I assure you that everybody on the front row has showered. So please do come forward and join the throng. There's lots of seats in the front, and please do come and use them. So if everybody could come on in, there's lots of people coming in through the doors. So my job is to get through the programme and for you to all be able to get home on time. But that means that we need to make sure that we start on time and everybody comes back from breaks on time too. So let's make sure that happens. Okay. So good morning, everybody, and I am absolutely delighted to welcome you all to our annual scientific meeting in person. And the number of people who've said to me this morning and last night how great it is to actually all be together. We've done our last 2 meetings online, and they've been a massive success with a lot of work. But it is really good to be able to meet people, and many people here are meeting in person for the very first time. So take advantage of that over today, and we've got plenty of space for breaks, and make sure that you do meet people, that you talk to people you haven't met before, and introduce yourselves, and make good use of that time. So for those that don't know me, I'm Ashley Adamson. I'm the Director of the School for Public Health Research, and it's my privilege to be able to start this morning's session. So the first thing I have to do is a little bit of housekeeping. So fire exits, there isn't a fire drill plan, so if there's a fire exit, please take that as being a situation to respond to. There's 2 sets of stairs. The ones here are the quickest, and fire exits are out the front and also around the corners of the hotel. Toilets, for those who haven't found them yet, are out through that door and round to the right. We've got lots of breaks and refreshments during the day, and if you're wondering when they are, as if by magic, if you turn your badge, you'll find the programme on the back of your badge. So that means that you've got a nice, easy, quick reference to when your breaks are and when they should finish. The posters are going to be in the room just to the right, to the left, and then immediately to the right, the posters. So please do go and see those posters and talk to the people presenting. They've put a lot of work into them, and it's great to be able to get a bit of a conversation going with our new PhD students, particularly who are starting their studies. Wi-Fi that is here. So it is, Mellor Events is the network, and the password is Mellor Events. Okay, so if you haven't found the password yet, it's there, and it's also on posters in and around this space outside. Oh, thank you, Claire. So this is the programme. I'm not going to go through that because you've got it on the back. And if you could just move on to our next slide. If you want more detail, we haven't printed the full programme, but there is a full programme which you were sent as links and also on this QR code. So please scan the QR code and you'll get the full programme with all of the detail that is being put together. And my thanks to the director team, but particularly to Amy Johnson, who's worked really, our comms manager, who's worked really hard on that programme. So do take time to have a look at that. Okay, so my next slide is, just before I do that, we've got the Twitter handle on the bottom here. So please do take some time and get onto Twitter and tweet about the speakers and also about their meeting and people that you're meeting. Take time to interact with others in the network, and particularly for the PhD students and postdoctoral fellows in that room. And the other thing is, in terms of any feedback that you have after this meeting, we'd be really really pleased to get that in terms of format and other aspects of the meeting. So please let us know about that. And then the other thing I want to draw attention to is our the mental health. This is Mental Health Awareness Week, and I think people might be being involved in other activities. One of the things and there was a run and a walk this morning. So well done to those people who went and enjoyed the quayside this morning for either the run or walk. And thank you to Amy Johnson and Katie Appleby who led those. We are doing, the other thing to mention is that the room after the posters room, which is called the Big Ideas room, is a quiet space for today. So if anybody feels like, and it is sometimes, if this is one of your first in-person meetings, it can be a little bit overwhelming, suddenly being surrounded by lots of people when you've not perhaps had that for a while. So there is a quiet space called the Big Ideas room. Please do use that. And can I just ask those people who might be looking for places to make phone calls and other things, if please do respect that space and keep it quiet. There's lots of other places around the hotel that you can go to make those calls or anything else that you might need to do during the day. And I think there's an exhibition in there around from public involvement, which I think would be self-explanatory. So do go and have a look. So today we are celebrating our awards. These are our inaugural awards, and we're going to have awards for our public involvement, for our EDI, and also for our posters and today. So we will look forward to presenting those posters later on today at the end of the day, and thank you to all of those who volunteered to be a part of our judging panel for that. We have tried hard to this meeting to think about sustainability, and we've been working very closely with our events partners, Beacon House. We're going to be serving vegetarian and vegan lunch and refreshments right through the day. And when you registered, we've asked you how you've travelled, so that we can then try and look at the carbon footprint of the meeting, perhaps as a baseline against which we can look to improve for our next meetings. So I think that is probably. Oh, I have one more thing to say before I hand over. We have got a photographer with us today. Tom is in the corner, waving his hand. If for any reason you would prefer not to be in any photographs today, please let Tom know, and he'll make sure that you're not. The photographs will be used on the website and in our newsletters and in other comms. So if you would prefer not to be in that photograph, please let Tom know. And if you don't, we assume that you are content, and we look forward to seeing your lovely faces on our newsletter and on our website. And then I think finally from me, I just want to say some thanks. So thank you to my Fuse colleagues who have been involved in preparing and hosting the meeting, and they're at the back of the room if you want to talk with them. To Beacon House and to Katie particularly, who has our events management, who's really worked hard with us today, and also through the last 2 virtual meetings has actually made sure everything has worked smoothly. And also I'd like to just right now thank the people from across our members who helped with the scientific programme for today. So that is Peter Craftnell, Louise LaFortune, Cheryl Maguire, Kaya Hurley, Joyce Coker, Jenny Parnham, Rachel Proctor, Rebecca Mead, and of course the school directorate team, without whom none of us would be here. And also your administrators, of course. So I think that's me for this morning to get us off up and running. And I'm going to introduce Rona Campbell, who is our Academic Capacity Development Lead for the school. So, and Rona's going to tell you a little bit about capacity building. Okay. Thank you, Rona.
Good morning, everyone. It's wonderful to be here, and a very warm welcome to you all from me too. There are an awful lot of different groups of people who contribute to the school, and it's lovely to see them all in the room. So a very warm welcome to some of our advisory board members who I think are here today, to, of course, all the academic researchers who are here today, to the programme leads who do a lot of work and whose work you're about to hear about, to our public contributors, it's lovely to meet them, to our public health practice colleagues, and to all the administrators who have also come to Newcastle. It's really wonderful to see you all today. And from me, an especially warm welcome to our early career researchers and trainees. We were up here yesterday and we had a fantastic researcher network meeting yesterday, but for quite a lot of those folk, this is their first in-person advisory board, in-person scientific meeting. So I hope that they also really enjoy today. So, for those of you who are not familiar with the capacity building that we do, this diagram summarises all the different components of that. I'm not going to go through it in detail because there's a lot of information on here. But as you can see, it's quite it has quite breadth, this programme. So we have it starts with summer internships, and we're just they're just about to get underway. Then we have pre-doctoral fellowships for people who are qualified at master's degree level, may or may not want to go on and do a doctorate. This is their chance to find out. Then we have PhD studentships, which are for 3 years. We have launching fellowships for people who are postdoctoral and who need a bit of that sort of bridging into more independent research careers. And we also offer research funding for our early career researchers. And this new for this quinquennium, we're also offering transdisciplinary placements this summer, and fellowships will begin next year. So a very full programme of work that we do. We also, of course, offer lots of training events too, and we do that in combination with our NIHR Academy colleagues, also with the other 2 national schools that we have in primary care and social care. And we also now wonderfully have an alumni, some of whom are also here today, which is fantastic because they're really engaged and want to carry on contributing to the school. So these are our new trainees for this quinquennium. And I hope you'll all get a chance to meet them and view the posters, the lovely posters that they've been making. And the fantastic thing about this is that we prepared this slide only a few days ago, and it's already out of date because we have people constantly joining us. So not on there, Andy Mahan and Kat Holt, who have just joined us in Bristol as PhD students very recently, and they are with us in the room, but they haven't quite got their pictures sorted out yet. So yeah, please go in and talk to all our trainees and appreciate their posters. And this is what we're going to be doing in the very near future. So I mentioned that we've got transdisciplinary placements. We've offered 5 of those, and those folk are going to be starting from June. We've got our second round of PhD student interviews, also in June. And we've got summer internships there being recruited at the moment, and they will be starting working with us because they're undergraduates, usually in the middle of their degree, so they just come and spend the summer with us. Our ResNet funding call, so our early career researcher funding call, has been launched with applications due in at the end of July, and we will be launching a second fellowship competition in September. And again, new for this year as well is we're going to have a route for people who are not in a position to take up PhD studentships, but a route for people to do PhD by publication. So that's enough from me for just now. I'm going to hand back to Ashley. Thank you.
Thank you, Rona. And I think just the array of work in terms of capacity building that is ongoing there, and just as a reminder that actually at the beginning of our last 5-year period, we had no capacity building function, official capacity building function, although we did have people who obviously were building their careers through our researchers. We didn't have facility to be able to offer funded PhDs, pre-launch, pre-doctoral, or any of the things that Rona said. So my huge thanks to Rona and to Andy Searle, who've really built this programme, and also to DHSC, who've given us additional funding for our capacity building. And it's great to see how people have come on from that and welcome the alumni back with us today. So now, I hope you've all noticed that we're in Newcastle. And it's lovely to be able to have welcomed you to the city. And I know many of you were here last night and went out and enjoyed some of the city, and you may even have gone as far afield as Gateshead by going across one of our beautiful bridges, because on the other side of the river is, of course, Gateshead. And you may remember at one point, some time ago, we did have a meeting in Gateshead and met Alice Wiseman, who's the Director of Public Health in Gateshead. But today I'm really, really delighted to be able to introduce Lorna Smith. Lorna is here with us, and she's going to tell us a little bit about Newcastle and some of the challenges they face. And Lorna is the Interim Director of Public Health here in the city of Newcastle. So welcome, Lorna.
Thank you very much, Ashley, and good morning, everybody. I'm really delighted to be here and welcome you to our city. I hope you've managed to enjoy it last night and today and get some time. I have had the real privilege of being the Director of Public Health for 14-15 months now in Newcastle, as well as the Deputy Director during the pandemic. So you may have spotted I'm not from here, but I have really seen in the last few years the exceptional character of Newcastle. We've got an incredible health system, not just in terms of our outstanding trusts and the academic institutions, but we've got real character as a community. They're very hardworking, very generous, very tolerant residents in Newcastle, and I think that's shone through, particularly in the last few years, and especially during the cost of living pressures that we see as a system at the moment. So I'm just going to talk a little bit about Newcastle in terms of our public health context, and some of the things I think we need to think about as a wider public health community, and how Newcastle's situation hopefully translates, and there's some learning for us all in that context. It's particularly important for Newcastle to be having these conversations and make sure myself and my colleagues are articulating what a public health approach means, because we are delighted to have received NIHR funding for the Health Determinants Research Collaborative this year, and we're on a journey. And what I'd say is, while it seems very obvious to public health professionals why public health sits in local authorities and the opportunities we have, I'm taking nothing for granted in terms of my local authority colleagues understanding that the scale of the opportunity we have from that grant and what a public health approach means. So stolen from my DPH report, so it is mine, but it's repurposed for today. This is a map of a Geordie life, of the average statistics around a range of health and social indicators, and I particularly wanted to highlight social indicators because it is a document that is speaking to our residents, but also speaking to my colleagues, not to public health professionals. And I wanted to really make sure it wasn't a document for us in terms of our interests. So everything that we know in terms of our evidence base of, whether or not you own your own home to whether or not you finish school with qualifications is of course important. But what I'm really mindful of in terms of our use of data and statistics is there is no average life. So this is the average life, but what we also know is the distribution of disease, illness, health outcomes is not equal. So nobody has this life. What this doesn't reflect is our variation, and that's where we need to focus, because we know that the children who don't receive the immunisation are also those more likely to struggle in school and more likely to be more at risk of substance misuse. So I think our role is to use these data to explain, and sometimes be very explicit about why we're highlighting these data. For example, if we took proportion of teenage mothers, that in itself, and using that statistic, can be used to stigmatise or to otherize, or to just be used as implicitly a negative in terms of our standing relative to others. But actually, the reason that's important is because all our knowledge and evidence tells us that young mother is at risk of income inequality, of barriers to employment, to education, at risk of social isolation, less likely to breastfeed. And that impacts her life course as well as the child's. And I think that's often what we need to be very unashamedly empathetic about, is that's why it's important. And that's why we're describing people in this way, because people know how we describe them. That's what's really struck me in terms of the pandemic. There's a huge appetite and interest from our communities in public health knowledge, and our responsibility in terms of public health literacy is not to distance people from these data, but to empower them with describing what that actually means and why it is important we use these data. So these are both pictures of Newcastle. They're about 15 minutes apart. Some of you might have seen the beautiful quayside I showed on my first slide, and you might have seen the leafy, lovely parts. These are quotes from residents. And it just strikes me as, if you're in a privileged role and if you are part of the public health community, you work in the hospital or the universities, often what I hear is it's such a lovely place to live. Low house prices, leafy green, you can cycle into work in 20 minutes. What a nice place to be. However, if you're also part of the public health community, you might say, gosh, we've got the worst health outcomes in the country. The North East is known for highest drug-related deaths, for our smoking prevalence, for our low life expectancy. And in Newcastle, we've got 43,000 food bank users out of our 300,000 residents. So people's experience is very different, a mile apart. And I know within the public health community, we talk about the inequalities in a very factual way, but it almost dulls our outrage. That's not okay, because for me, the inequality in itself demonstrates the potential of where we should be. There's absolutely no reason that everyone can't enjoy Newcastle being a green city, a friendly city, a city you can walk everywhere to. And that's the real challenge I hold up to myself and my team. So some boring health statistics just to prove that in themselves, they're not helpful. So these are just the 5 most common causes of premature mortality, so before the age of 75 in Newcastle last year, and also the most common causes of chronic diseases. There's probably no surprises there, especially if you're familiar with the North East epidemiology, but I guess the take home for me is they're all socially patterned, and arguably, although there's possible exceptions, they're all related to the 4 health behaviours, and we know loads of information and evidence. And I suppose what we also know is they're all preventable. We're drowning in evidence about how they are linked to causation and how all 4 of those behaviours are also tools for intervention and for secondary prevention. And what we need to stop doing, I think, as a public health community is describing the problem, because people don't see themselves as someone with ischemic heart disease or someone with diabetes or someone at risk of diabetes. And we saw that in the pandemic. People see themselves as a mum, see themselves as someone tired, see themselves as a carer. And often people who are in one of these categories will be in another one of these categories. And we all know the likelihood is so will someone in their household, in their family, in their generational history. So my challenge is really, do we just accept this? Of we've just got really poor health outcomes, and these are the things people will die of and be ill of for a long time. So I think that's my real challenge is it's a distraction to focus on the health outcomes, because currently, you'll all know in terms of the media, the national conversation, we're arguing over how many GPs we need or how many new hospitals we need. And the elephant in the room is we're sicker as a population. It's not about treatment and care. It's about prevention. So for each of these elements, what we need to think about is if you are overweight or obese, you have limitations, you've probably got more absence from school or work, you might live in pain, you might live in shame, you might have low well-being, you might feel isolated. That's the person behind that statistic, and that's where we need to take the conversation, because then we start to look at solutions within the wider determinants and not within the health system. And that for me is the real challenge. If these are important, and we do need to compare them, but to prompt action where it actually makes a difference. We can't cope with these pressures right now, and actually there's lots of ghastly diseases we want our health system to focus on that aren't preventable, or not yet anyway. So just very briefly, this is Newcastle's population pyramid. Public health colleagues will be familiar with, we use pyramids for various reasons. You'll spot we have a young age profile, and often population pyramids are used in order to plan services, and sometimes when we're doing worse than the rest of the country and things, explain and interpret data. So, this was wheeled out as to why we were the worst in the country in COVID vaccine uptake, and it was because we didn't have anyone eligible yet. We were a young population, we've got lots of students. But actually, if we just not think about how we're using it, and we just looked at this tells me, and it's my challenge to myself, of we're younger than most of the country, and youth is associated with economic activity, ambition, vibrancy, and good health. Unfortunately, what we've got is long-term morbidity and sickness. So actually, people become iller younger, and that's all to do with the life course that they're set on, often before they're even born. So that's my challenge to my team is, why do we strive to be like the England average? Let's be the best in the country because we're the youngest in the country. So to counter the population pyramid, this is again a graphic that I developed for my DPH report published in January. And you will have seen similar infographics, but this is about if we were a toon of 100, and the toon is the shorthand for Newcastle, for those who don't know. Because I do think we sometimes forget public health as an art and a science, and we focus a lot on the science. And as someone who's in awe of the brilliance of my academic colleagues in the room, I have had 4 years of doing good enough and being very uncomfortable with it. But a lot of that is the art of the applied public health, of actually how we get things done and what we do. So the idea of the toon of 100 is obviously we don't just describe data points and people as statistics. This is trying to encourage empathy and context, because if we were a wee village of 100, we might have a bit more understanding of someone's lives. So I have banned the term hard to reach in my team. People aren't hard to reach, they're right there. They're maybe not shouting up and down about their health because they're living their lives. They're underserved, and we're failing them in how we present them. So just as an example, if we were a wee village of 100 and we had 17 of the village living in fuel poverty, we wouldn't just think, oh, fuel poverty is on the cold days. And I've colleagues who are very experienced, very senior across the system have said when it snows, oh, fuel poverty will be a problem today. We've got fuel poverty problems as an annual issue, and it's everything from people who use food banks have stopped asking for vegetables that need cooked because they can't turn the gas hob on. What contents can be consumed cold. We've had families with infants in the house who have no hot water and no ability to heat water. So when we talk about fuel poverty, if you actually knew that family in the village, and it was 17 of the 100 of us, you would know it's not about the cold days. It's about we've got community washing machines because people can't put the washing machine on in their own house. And I think what I really try to convey is it's not that in itself, it's how that makes people feel, because that's actually the difference. If you don't feel you're in control, if you don't feel you matter, if you don't feel you value, then why would you actively make health choices if you have any in front of you? So that's what I really tried to get across with this, of what are the social norms and expectations of our community. And this is, and apologies, it's not the clearest slide, but we all know this. So I guess what I've tried to describe is, we focus on health outcomes and use that as our measure. And we can relate them back through evidence very easily to what are the health behaviours. And we can say, well, these are the things that cause them. But this isn't related to how people think. And what struck me, particularly through the HDRC work, is this isn't implicit to people. People don't think like this. But if that was your kitchen, you might take the kids out for a McDonald's because your landlord's not returning your calls and they won't fix the cooker and you can't clean it. And then over time you're overweight. And the narrative is you need to make better choices. So again, I just think we should be unapologetic in reminding people this is all in our heads and this is how we see the world. And they don't, and they really don't, in terms of professional colleagues in working across the wider determinants of health. So I'm conscious of time, and I'll just, on this last slide, this is a product of, and apologies, it's not, the text is small, but this is a product of my frustration at everyone now wanting to work on inequalities, and they all think they're doing inequalities, and it's a buzzword, and we've got a lot of capital in inequalities, which is great, but we need to be specific about which inequalities, who's positioned to actually influence them, and where are they? You know, working with ICB and NHS colleagues, you know, they're absolutely desperate to work on inequalities and address them, but them pedestrianising our city or trying to influence that isn't where we need them to work. So this is just a framework, and I'm happy for these to be shared in terms of social inequalities, health inequalities, which are our outcomes, and then healthcare inequalities, and they're quite different in terms of who's positioned to influence which ones. So I guess my ask is that we really consider the data and statistics we use to describe our places, our city, our communities, the people who we're actually here to serve, and think about who is actually placed to interpret, to examine, to explain, to influence by joining data and working together through jointly asking the right questions and forming the right opportunities and interventions. So be unapologetically explicit. I have learned people do not know what they mean when they say inequalities. They don't know why a statistic is important and what it means. So that would just be where I'd end. And just, I've got some links to our public health department, which includes my DPH report, as well as our health determinants collaboration, and my email address. I will, all being well with my pregnancy, I'll be here till September, but happy to chat to people today as well. Thank you.
Thank you, Lorna, for that, and for perhaps giving us lots of food for thought as we go through the day, but also for all the work that you've been doing throughout the city. So thank you. So now we're going to come on and talk about our research and understand a little more about our research programmes. And to chair this session, I'm delighted to welcome Penime Adab to this stage. Penime is the Deputy Director of the School for Public Health Research and will be chairing these sessions. So Penime, please. Thank you.
Thank you very much, and welcome everyone. It's lovely to see all of you here. I am delighted to have the opportunity to introduce our speakers for this morning, I think following on very nicely from what Lorna said and the challenges. So our research programme for this quinquennium tries to think about the research needs that address some of those challenges. And I think everyone is aware that we have 4 research programmes. So our research programmes, in the order that we're going to be talking about them today, are health inequalities. We've got healthy places, healthy planet. And then we're going to have a short break, and after the break we'll have presentations from our children, young people and families, and public mental health leads as well. So to start off with, we have with us Claire Bamborough and Jenny Pope, who are our programme leads for the Health Inequalities programme, and I'm going to ask them to start us off. So thank you.
I'm just going to stand with me. I've been told to stand up so you recognise me, and I'm going to sit down and Claire is going to do the presentation.
As if anybody was in any doubt.
Super, okay, so I'm Claire, she's Jenny.
Right, well, thank you very much to Lorna for a really illuminating talk, but obviously a nice segue, or not so nice, depending, into what we're going to do on the Health Inequalities programme. And as I've only got 2 minutes before colleagues come and talk about more detail, you saved me what is a much more boring-looking slide than yours, but saying the same sort of thing, that you described some of the inequalities in Newcastle. We can obviously see those health inequalities across the whole of the country in different regions that the school represents. The trends over the last decade have been increasing health inequalities between more deprived and more affluent areas. We then had COVID, which has exacerbated this, as Lorna's slide show. It was one of the top 5 causes in Newcastle of premature mortality last year, under the age of 75. Obviously impacted on deprived areas very heavily, particularly also in the north, but also a massive impact within minority ethnic communities and in other more vulnerable groups, including people with learning disabilities. And that will come back to that later in some of the work that we're doing in the programme. So basically a decade of not great news for health inequalities, the cost of living crisis on top. Obviously I'm setting it now up to how we're going to solve that. No. If only, but we will be doing our best to help public health practice policymakers nationally and locally in terms of their thinking and what they're trying to do to address some of these health inequalities. And so the programme has started. It will run for the full term of the school, and our aim is very much around this. What can we do as a research community to support people like Lorna and our colleagues in other parts of public health practice and the wider health and social care system? We've got various principles. We want this to be very much, as Lorna was saying, about not just the health outcomes, but also those social inequalities that are driving it. And that, as we saw through COVID, are very structural and embedded within our society and the systems that reflect that. So we're talking not just about sort of deprivation, but also ethnicity, gender, their interactions, looking at people from disabilities and so on. We'll be trying to take a more systems perspective about how the different parts link together and what we can learn and understand from that point of view. And building on Pemone's and Rona's comments, very keen and hopefully beginning to build capacity and encourage future researchers within the school, within the health inequalities space. We're going to have 2 large work strands within our programme. The first one is looking at what will be, in a shorthand, the levelling up agenda around health inequalities, but looking not just at what we might be getting from different parts of national government, but also what actions are happening locally and within the community and voluntary sector and other public partners. And the second strand, which also there is some overlap between them, is looking at very much on that community basis. What's happening within particular community knowledge partnerships on the ground, and this is particularly focusing on more marginalised communities such as coastal communities, minoritised ethnic communities, people with learning disabilities, and people experiencing the social justice system. We've started over the last 6 months or so in a phase 1, developing, piloting, recruiting, and then into the autumn we'll be going forward with a second phase. But I'm delighted to invite up colleagues to talk about all the details. I just get the easy bit. And so I'll invite Emma, please, and Rod to come and talk to us about the work strand 1.
Great, thanks very much, Claire. I'm presenting just a short overview of the work strand 1, levelling up work. But firstly, wanted to acknowledge Rod Lieber, who's co-written the slides, and also I think Alan Griffiths, who should be in the audience, who's also a public partner with the project as well. Our research strand is very much about looking at how we can produce effective evidence around the policies and actions that can address social inequalities in health. So very much the types of issues that Lorna was talking about in her presentation, as we've just heard. In this first phase, we've got 2 main purposes, really. We firstly want to just get a much better understanding of what levelling up is understood at the local level, and also the work that's happening around pandemic recovery, and also sort of undertaking work to help develop the kind of longer-term research plan, which will be continuing into the second phase, which we hope to start in 2024. But for those of those people who may not have come across the term levelling up, there may be a few people, just to give a brief overview of what it's understood to mean. So very much levelling up has come across as a national policy ambition at a national level, I guess exemplified through the Levelling Up white paper, the various funding streams that are coming down to the local level. So as you can see from the quotes, some of the highlights from the white paper, talking, for example, about it being a cross-departmental or cross-government strategy, addressing some of the geographical inequalities, which Claire sort of referred to in her slides. But also the white paper also talks about narrowing the gap in healthy life expectancy between areas of the country. But of course, that's sort of what the national kind of picture, and we really wanted to understand a bit better about how's that sort of seen at the local level, and how does this all fit into work to address health inequalities. So to do that, we've started with some workshops with policymakers, practitioners, and also members of the public through a series of online and face-to-face workshops in different regions of England. So we've just finished 4 workshops with largely local authority professionals and also their colleagues working in other sectors. And again, these quotes on the slide just give some indications of the sorts of issues that were coming through those discussions and how they were sort of thinking about levelling up and potentially some of the wider issues as well. So, for example, in the first slide, a reflection about a slight concern that perhaps the official levelling up focus is too much on the infrastructure and the economic focus rather than the wider sort of community needs and perspectives as well. But understanding locally that, in some areas that was very much something that people were trying to drive through as well. But then, for example, in another area, the local authority professional we were engaging with, talking about actually the levelling up agenda being an opportunity to have those conversations with other departments to try and leave it a more of a focus on health and all policies as well. And then just a final quote, I think already sort of brought up in Claire's slide as well, about this, the wider issues and challenges that people were facing through sort of the ongoing effects of COVID, as well as the cost of living crisis. So in thinking about our research as well, that obviously really exemplifying the importance of thinking about how inequalities may continue to rise and may be also affected by these issues, as well as the positive action that's being taken locally. So moving on then, alongside the workshops, we're also undertaking some more desk-based work, really sort of scoping a whole range of policies and actions relevant to social and structural determinants, whether that's housing, transport, living conditions, and so on. That's been happening in a fairly diverse set of areas through local conversations and some documentary work. And again, we'll be hopefully coming back to people in the next couple of months with some initial findings from that mapping to really test out and get some feedback on whether this is really reflecting the picture in other areas as well. So those 2 bits of work have very much been focused on just getting a better picture of the local landscape around levelling up and pandemic recovery. And then moving on, we're now sort of really focusing as well on thinking about methods, approaches to data. So one strand of that work has been sort of scoping the sorts of available data that tells us more, as Lorna was talking about people's living and working conditions, both qualitative and quantitative data. And then the second strand as well, feeding into, what do we need to do to make sure that we can really understand the picture of health and social inequalities through the data we collect. So just to sum up then, in terms of the next few months and then years ahead, we're working towards this longer-term evaluation of local policies and actions relevant to social determinants, structural determinants. The focus of that may, as Claire talked about, have a really strong systems approach where we're actually trying to look at the effects of collective actions and policies rather than just single interventions, and that's something to explore in a bit more detail. But certainly it will involve capitalising on the school, undertaking the research in different regions of the country to look at what works for different groups in different areas. We'll continue to co-produce research with my colleagues such as Rod and Alan and others in local areas, and then we'll be hoping to get that research underway and continued in early 2024. Thank you.
So thanks, Emma. And Steph's now going to talk to us about work strand 2. Thank you very much.
Hi, morning everyone. It's a pleasure to be here. That was a nice good morning, thank you, whoever that was in the front row. So I'm just going to spend a little bit of time talking to you about what we have been doing in work stream 2. Now, earlier this week, I made a bit of a mess trying to include all of our academic and community partners, and I missed people out and people were offended, so I went with a university community partnership. That's what we are. Yeah. So the project rationale. This project really stems for a need to bring together community organisations and universities. So what we're trying to do is co-create knowledge partnerships between communities and universities, basically. And it's responding to a deficit in looking at intersectionality and the persistent lack of value, if you like, looking at what community organisations do and the populations they serve and the work that they contribute. And then in terms of social harms, that's something that this project's trying to address as well. So we're really trying to push the boundaries and redefine the terms of involvement through rebalancing power and embracing new ways of knowing. So we have 4 substrands that we're looking at. So we've got our racially minoritized groups, we've got people leaving the criminal justice system or involved with the criminal justice system, coastal and rural communities, and people with learning disabilities. There is some overlap between those groups, and we're in quite close communication. And as we're getting towards the middle of the project, we're starting to see where those overlaps are. So these are the project stages. We're currently sort of working in stage 2, so co-constructing those knowledge partnerships, although it is very evolving and overlapping. We're just starting to move into the 3rd stage, where we're looking at co-confirming research priorities and designing follow-on research activities. So the types of conversations we're having with our community partners are, what are your experiences of working with researchers in the past? How can we help your communities to thrive? How can universities help your communities to thrive? And how should we move forward together? So now we're getting to sort of the more interesting bit, I think, of the presentation, which is how these relationships are being formed. So there's been so much that I'm trying to cram it all into one slide. So we've held workshops, we've had community organisations calling us, we've been calling them, we've had online events, we've made animations, we have made kind of easy read resources to try and make sure that our information is getting out there and that people are understanding what we're trying to do, because I don't know if my partners who are in the room would agree with me, but a large part of this project is trying to get people on board with what we're trying to do and also understand it ourselves. It's been quite a creative process. So I'm just going to spend the rest of the short time that I'll be talking about the challenges and some of the opportunities. So I guess the first one is that community organisations are really busy. So our job is to research. Their job is to help the community. So us going in there saying, come on, let's get on board with this exciting project. They're like, you would love to, but we're very busy. So one way that we found is quite good at understanding their priorities is by attending events that they're already putting on. So showing support in that way. And it's kind of a very clear demonstration of what their priorities are if they're dedicating their time and energy to putting that on. And I'll talk a little bit later about how we're a team of sort of embedded activist researchers, if you like, in that we're already doing a lot of work within the community, and that also contributes to helping alleviate the burden that a lot of community organisations face. So tension between desires and deliverables. So we're starting to get to a point where community organisations are really excited about working with us, and we've sold this project really well. But at the same time, we have to be aware that we're selling it as very open-ended and a very, this lovely process that we're going through together, but it's trying to balance that with timelines, and that if we want to get funding has timelines attached to it. And obviously, the more people we have involved, the more expensive projects become. So trying to manage expectations is a conversation that we've been having within the work strand. Distribution of resources, so that's not only in terms of money, as I've just mentioned, but also in terms of time. We've been given this really great opportunity within the SPHR infrastructure, but looking towards the second phase, we need to get stuff down on paper, you know, so trying to balance that up is challenging. And then these power imbalances, so we're saying, right, we want to build these really equal partnerships between universities and funders and the community, but we hold the purse strings. So trying to kind of address that power imbalance is not easy, but they are conversations that we are having. And then prior relationships, this is both a strength and a slight weakness. So a lot of us within the team have prior relationships with the organisations that we're working with. Some of us are friends with them. Some of us spend times on the weekend volunteering with them. We're trustees in these organisations, which is great in one way because we're very embedded and we have a kind of innate or learned rather understanding of these organisations. But at the same time, it means that we have these ways of working which are quite hard to break out of, on both sides, both for us as researchers and community members. But then at the same time, particularly in the learning disabilities team, they have a wealth of knowledge of how to work with the community organisations. So there's a lot of good practice to draw on. And then the status quo, it's so easy to just go in and say, right, we're going to focus on this project. And community organisations say, yes, we understand, let's go. You know, because we're all used to working in that way. So trying to take a bit of a slower approach and not know what we're going to work on is challenging because everybody likes things to be in neat boxes. So just in the last couple of minutes, what I would like to say is that there's sort of indications of change. The word that comes to mind is embryonic, but I thought a shoot is nicer than an embryo, so I put that on there. So we're starting to have these very, I would say, uncomfortable conversations with community organisations. So they are asking us, okay, so you keep coming back to us wanting to research race and racial inequalities. Why are you all white? You know, why is Steph the only black person on the team? Which isn't the case in this team, but those are the sorts of conversations that we need to be having and that they are having. And also they're holding us to account. So they're saying, okay, you want this equal relationship. It needs to be funded. So, you know, how much is available? How much are we all going to get? Because we need that money to do work in the communities. Yeah. So there's evidence of this shift in power dynamics in that community organisations are coming to us and saying, yeah, we know you want to do something with post-its, but that's not what we're going to do today. You know, and that's what we want. We want to be challenged and we want to work in new ways. So as I've mentioned, we're a team of embedded scholars. Many of us work within the communities that we are working with on this project. So it's tricky because a lot of us, I think, we're sort of personally involved, but at the same time, I think it has a lot to contribute in terms of the projects that will come out of it. And now we're having community members coming to us saying, we want to research this, you know, which feels new, it feels fresh to anything I've worked on before. So I feel like there are some early indications of change. So basically what we want to do, just to reiterate, is push the boundaries and redefine the terms of involvement through rebalancing power and embracing new ways of knowing. So this is a very much watch this space presentation rather than we have a plan and we're going to stick to it and we know what's going to happen over the next few months. And then just finally, I wanted to just reiterate, we're really, really grateful to our lived experience experts and community organisation partners. We really feel the trust that they are putting in us to build these new relationships. Okay, thank you.
I was, genuinely. Excellent, thank you. So, yeah, any questions for the Health Inequalities Programme as a whole, not just me, although I'm happy to try. Yes, thank you, whoever that is. You're my best friend, depending on what the question is. Is it someone I know who... Go on.
Hi, I'm Lina Al-Qadairi, work university. Thank you for the excellent talk. I just wanted to ask about your engagement with community around priorities. I realized that when we attempted to do that, priorities keep changing as we go through. And by the time you get the bid ready, and it's just all passed by. So from a practical point of view, any challenges and how did you overcome them, please? Thank you.
Super, thanks. I'm going to phone a friend. Steph, I'm pretty sure this question's for you. Do you want to come up and bail me out? And if okay, Emma, would you like to come up in case there's other questions? I'm just a compere, right?
That was smoothly done.
Thank you. Yeah, I'm good at getting out of stuff, aren't I, Jenny?
So, yeah, I would say that is an issue, and there are a few models that we are sort of looking at. I don't know if anybody's heard of the Ignite model from Brighton, where they basically have this lovely pot of money, and as soon as a priority comes up, they sort of shoot out a project. So we're not starting from scratch when we're thinking about how we might be developing a network and the partnership. So I think drawing on other models that are doing it well in terms of addressing priorities in a quicker way, then you submit a bid and then you find out in 12 months that you haven't got it, and then, you know, all of that stuff.
And the work that Steph and colleagues are doing in Workstrand 2 could, over time, lead to, you know, a new model.
Yeah, well, I mean, that's
then
the
other
intention.
people could use within public health to be, in a sense, more responsive to community needs that we don't know that they need, if you see what... Is that right?
Yeah,
Great.
that sounds right.
Thanks.
Hi, thank you so much for that. I just want to ask all of you, including Lorna, does change with levelling up happen at the bottom and allow change not to happen at the top?
Or does no change happen at all? Well, can I do my political answer and then you can... Yeah.
Go ahead, yeah.
So that's what we're going to find out, obviously. But more detail, Emma, do you want to...
I don't know if it's directly answering your question. I think what's been quite interesting with the discussions we've been having is around the language of levelling up, and yeah, so very mixed views about whether people were comfortable using that or whether they actually did use it in practice when they were talking about health inequality. So some colleagues, for example, talking about being more comfortable with talking about the Marmot principles. So I don't think that really answers your question, but just give some insights into how it's been thought about locally. Jenny had it.
I was just going to say, in response to the reviews of the programme, we've also begun to focus on those dynamics and processes which are undermining. It was termed levelling down. It's not levelling down, actually. That suggests that the top might be coming down, which, but those processes that undermine attempts to reduce inequalities are going to be a focus of the programme now. So in part addresses your point.
And Steph, could I link it across to your work? You know, is it something that comes up at all as a phrase, as a topic in the work that you've been doing with different communities?
Yeah, I think so. And I think, if you don't mind, give a bit of my personal opinion, I do worry about running around in the community and putting additional burden on the community to do more does leave these kind of wider structural inequalities intact. But having discussions with our community partners, getting a seat at the table to talk to decision makers and using our sway to get a seat at the table is possibly something that we could do. So no change guaranteed, but it's about using that privilege in this position to have a voice or give communities a voice, I think.
Thanks. Brilliant. Thanks, guys.
I'm sorry to cut the questions short, but we're just running a little bit behind. So we're going to move on to our next programme, Healthy Places, Healthy Planet. And I'd like to introduce Matt Egan and Frank de Vot. I hope they're here. There they are. So please go ahead.
Thank you. I'm Matt Egan, London School of Hygiene and Tropical Medicine. Frank?
Sorry, yes, I'm Frank de Vocht from the University of Bristol.
Similar to before, we'll shoot through our bit as fast as we can and get to the more interesting bits, which are presentations by Katie Powell from Sheffield and Patricia Albers from Bristol about projects that are, in the first case, has started and in the other case is going to start. So Healthy Places, Healthy Planet combines concern about health and place, and of course environmental sustainability and environmental issues. So that's the two things that the program covers. Around about this time last year, we had a series of workshops with researchers, practitioners, and the public, and we wanted to scope out the areas of interest and concern that could fall into the program. And one of the big sort of take-home messages of which we developed our challenge around really fits in, I think, with what we've already heard today, which was this idea that being healthy and living sustainably should not be a privilege. And in particular, the public people we spoke to felt that it was a privilege. There were lots of barriers and difficulties to living a healthy and sustainable life that felt outside of individual control, and that applies to everybody. But in particular, people felt that people with less resource and other kinds of disadvantages felt those barriers to a greater degree. And they mentioned quite a few different themes, of which some are listed here. Things like, you know, the cost of living a healthy, sustainable life, matched against low incomes and low pay, and also more generally difficult working conditions. The way unhealthy and unsustainable products are advertised. And then there's things that are, again, kind of outside the individual's immediate control anyway, which is things like pollution and unsustainable practices outside people's control, poor regulation and underinvestment in services that might impact on sustainability and health, discrimination, barriers to collective and community action, and other kind of external factors. And people mentioned at the time things such as the war in Ukraine, Brexit, COVID, inflation. So we wanted to put together a program aim that would encourage people to produce evidence that would help move beyond the problem space and into the solution space for these issues. So as a main aim, we wanted to generate robust evidence to support policy practice and community activities aimed at improving population health, and health and environmental equity and environmental sustainability. And basically our objectives revolve around encouraging our colleagues to collaboratively put together some evaluations of interventions that can help improve environmental sustainability and health with an equity focus and often a co-production and systems focus. So those are my 3 slides.
Thank you. Yeah, so just to then take that forward, so graphically we envisioned our program to look like this. So an integration of Healthy Places and Healthy Planet, which were originally 2 programs, to bring that together with some nice overlap. We have a specific interest in place-based levers and sustainability, and we asked people to think about projects in those areas. And within that, we have the quite broad idea of looking at harmful exposure, sustainable practices, workplace health, and harmful commodities with as an overarching idea of what we wanted to look at, with equity at the start of, or at the center of it all. So we took that forward, and what I now understand is a very old-fashioned way. After the last presentation, we asked for project proposals, and then had a sometimes quite painful process of a year in which we reduced all the ideas that came from all the SPHR researchers, which was, just to give you an idea, it's just over 70 initial projects, and we dwindled that down in various steps to what we have now. And our project is indeed a traditional project, and we've come up with a program of 5 projects for what's the first round of our program. And to give you an overview of these, so conceptualizing local systems of consumption that produce inequalities in the nighttime economy is a project already started and is led by Katie from Sheffield, and she'll be presenting about that a bit more after my short talk. And then the 4 other projects that are about to start deal with community-led interventions to maximize health and well-being of climate change adaptation, led by Exeter with various partners. The evaluation of active and sustainable travel policies in structurally disempowered rural communities, led by Exeter. Effects and mechanisms of traffic restriction schemes outside of schools, led by Cambridge. And finally, the understanding the impact of mandatory energy calorie labelling in out-of-home environments in England, led by London School of Hygiene and Tropical Medicine, and lots of collaborators from other SPHR institutes. What that looks like in practice for our program is as I mentioned, the first project of the nighttime economy has already started and will run until early 2024. Then the other projects are about to start and will take us into 2025, early 2025. So we'll start to see outputs of these next year and the year after. That doesn't, in contrast to the previous program, we didn't completely map the full 5 years of our program. So after, in 2024, at the end of 2024, we have a second round in which we hope to commission another 2 projects. In between, we have one more project that I didn't mention, which may start a bit later this year, but has to be approved yet, so it's not included here. So we will have new projects coming in near the end of the project to make us to fill our full 5 years of our program. That brings me to the little bit that I have to say. We thought it would be interesting for you to have a closer look at 2 of our projects, the one that already started first, and then after that one of the more environmental and sustainability projects, which will be presented by Patricia Albers. But first, I'll hand over to Katie, who will present inequalities in the nighttime economy.
Hello, everybody. After an early start from Sheffield, I definitely need my notes. And thank you for the chance to speak about our project, Inequalities in the Nighttime Economy. I'm trying to use this shorter title rather than the convoluted one that Frank showed. This is our research team. We're based across Sheffield, Bristol, and the London School of Hygiene. We're from 8 different disciplinary backgrounds, but I think we're managing to communicate effectively despite that. But it's been really nice forming this new team. What unites us is our shared interest in the role of commercial practices in place-based health inequalities. So the starting point for the research is that products sold in the nighttime economy cause more harm in disadvantaged places. Alcohol in particular causes greater acute, long-term and second-hand harm. And alcohol is connected, of course, to a range of other products sold and consumed in the nighttime economy, notably high-fat, salt-sugar foods, gambling products, and tobacco. And those products, in combination with alcohol and separately, cause more harm in disadvantaged places. And as the second column points to here, what's important is that the explanations for unequal harms overlap those different products. So, for example, there are unequal levels of exposure to advertising of these products, shaping the amount and type of consumption. And there are also unequal resources within communities to manage the harm from these products. So, for example, financial resources to buy alternative, healthier products or to support quit attempts. And research also shows that the explanations, these overlapping mechanisms for inequality, aren't easily articulated by people, even people with a role in the nighttime economy in managing this. So, on that basis, the premise of our study is that a framework depicting the pathways to unequal harm can support collective advocacy for change at a local area. So we're going to produce, with stakeholders, a framework that shows these pathways, showing how inequalities develop from products sold in the nighttime economy. We'll do that through 2 steps. Firstly, looking at literature already published on this topic. And secondly, by testing the accuracy of the framework that we produce through fieldwork in 2 local sites. We're taking a collaborative approach to reflect the importance of stakeholder perspectives in the framework. And we've built a core team of 13 stakeholders from local and national government who have expertise in managing the nighttime economy and harm from the products that I've mentioned. And we've engaged a group of over 50 others to advise on separate elements of the project. So I've made that sound very smooth, but as Steph described, there's been a huge amount of work involved in building those relationships and understanding how people are working. And there is a desire within that network to share practice in relation to the commercial determinants of health. So through our networking, we're facilitating opportunities for that. And I've just tried to indicate here some of the ways in which we're taking a collaborative approach to decision making in the project in terms of the scope, interpreting the literature, and designing our field work. And this is a very broad outline of our approach to searching the literature. We'll use researcher and stakeholder knowledge to identify some key texts and take that as a starting point to search for studies that explain unequal harms from our short list of products, starting with alcohol, high-fat salt sugar foods, tobacco and gambling products. And the aim will be to identify theories that are relevant to consumption in the nighttime economy. And we'll collate, evaluate and combine these explanations, and subsequently there'll be an assessment of evidence for the theories that we identify. I've tried to give an indication here of some of the categories that are emerging to explain inequalities from these products. There are a set of explanations, for example, relating to product exposure, including outlet density. Another set related to social norms, for example, that affect the safety of settings in which alcohol is consumed. But ultimately, we'll aim to depict the explanations in a systems map to demonstrate the connections that occur within the space of the nighttime economy. So we're using the idea of the nighttime economy as a way of describing the space in which these practices take place. Through the planned field work that I'll discuss next, the systems map will help us firstly identify how industry influences these processes we're describing, how they influence them locally. And second, it will identify where these processes can most easily be disrupted. So, informed by the literature review, we'll work with our stakeholders to design a participatory mappings process, which is a qualitative approach to unearthing stakeholder perspectives on a topic and bringing together their understanding to produce a shared systems diagram. So in this instance, we're aiming to produce an interpretation of systems of consumption in the nighttime economy that produce inequality. So we'll run this mapping process in 2 localities, 2 contrasting sites that will help us compare the usefulness of the map in places with different population characteristics, differing nighttime economies in terms of their scale and the primary users, and areas where there are differing approaches and interventions to manage the nighttime economy. So just to be clear, the mapping process will be guided by the more general framework that we derive from the literature, and the fieldwork will allow us to depict local systems and explore context in more detail. So I flagged up some of our key sources here, and please do get in touch with questions or further offers to collaborate, I think. Okay. Thank you.
Oh, it's already here. So the next presentation is by one of the projects within the environment and sustainable part of our program. It will be done by Patricia Elvis from Bristol.
Thanks, Frank. Good Good morning, everyone. As Frank has just said, I'm Patricia Elbers from the University of Bristol, and I'm presenting this project on behalf of the project team who are unfortunately not able to be here today. I don't have a short title, so it's a long one, but you've heard it before. And we're a collaboration between the University of Exeter, the University of Bristol, Lilac, and Fuse. So just by way of a short introduction, climate change is considered the biggest threat to human health. So I've included this diagram which just kind of shows the pathways and the mechanisms to the health impacts. And at the bottom are some of the health impacts, which include heat-related illness, respiratory illness, and even mental health. Extreme weather events are increasing in the UK, and as a result, the UK government has declared this a priority. And in April of this year, they released the Adverse Weather and Health Plan. And as part of that plan, they identified 4 primary goals. And that's to prevent the increase in years of life lost due to these adverse weather events, to prevent mortality and morbidity due to them, and also to reduce the use of healthcare services during these events. So as we all know, climate change adversely affects the most deprived communities. So in this project, we're going to be evaluating how groups of people within different communities can act to reduce the health consequences of these extreme events, and we're specifically looking at floods, heat waves, and cold waves. So why are we looking at these community actions? Because by looking at them, we can identify any gaps in support or response, which could prevent health burdens, particularly for the most vulnerable people. And often these types of interventions are designed and assessed based on their risk reduction or economic impacts, but they don't often look at the health consequences. Whereas, for example, if you think of nature-based responses, that has a lot of benefits for health too. And then there's a lot of shared learning that can come across from the different interventions. So, for example, in the winter months, there's a lot of heat banks get set up, or warm banks get set up around the UK, and we could potentially take learning from that and apply it to heat waves. So in this project, we're defining community-led action as any action, activity, or response to a weather-related event. So that could be a community spontaneously responding to something that's happened, like a flood, or it could be them preparing for an anticipated risk, like a flood. And it can range from anything like providing skilled services, either to adapt or recover from an event, or it could be specifically supporting the most vulnerable people in the community. So we know that these types of community actions have a lot of success in reducing the risks, but we don't know the breadth or extent of them. And we also don't know particularly what it is about these actions that protect or impact health or are supportive of health. So these are just 2 examples of community-led actions against flooding. The one with the 2 pictures is from Yorkshire and the other is from Devon. The intervention in Yorkshire, they were able to reduce the chance of flooding from 25% to less than 4% in any one year. So both of these examples are examples of social learning between community members, researchers, local government, and other agencies, which could be charities. These initiatives are community-centered, and they encourage the participation of as many people as possible, and they draw from many local sources of information. So, for example, in the Yorkshire example, they drew from historical learnings that they found in historical records of what monks did centuries ago. From there, they then create a local approach to the risk, in this case was flooding. So with the Devon example, they created this resilience group that then worked with the town council to develop an emergency plan. And in that emergency plan, they planned to provide support, emergency and emotional, to the community. But they also specifically planned for vulnerable groups, and that included people with disabilities or even people who didn't have access to the internet. So the aim of our study is to evaluate how places and populations can be made healthier through these community-led actions. And we've got 3 main objectives. The first one is to explore the range of these community-led actions and to look at how they interrelate. And the second is to explore how these community-led actions support health and well-being, and how that can be improved going forward in the future. And the final objective is looking at how systemic inequalities are being addressed by and also affect the experiences of people and to do with these community actions. So this is a 2-year project with the hope of extending it to a 4-year project. So in here I'm just talking about the first 2 years. But in the first 2 years we'd aim to evaluate these community-led actions, and in the following 2 years it would be to create a community-led action. So in these 2 years, like I said, that's what I'm focusing on now. There's 2 work packages. So in work package 1, we're firstly going to be doing a review of all of these actions. That's going to be a scientific review, but also working really closely with stakeholders. And during that process of working with stakeholders, when we'll focus on exploring the inequalities and how they're shaping the experiences, which is links to the third objective. In work package 2, we're going to do an in-depth case studies. So we'll select a community-led intervention for flooding, heat wave, and cold waves. And we'll use a realist approach to evaluate these. And in order to do that, we'll do in-depth interviews, workshops, document reviews, and also a retrospective evaluation of the effectiveness and any barriers they encountered. And in the final activity, we'll then bring together all of the learning from both work packages and create a set of principles that we'll then use to, in the next following 2 years, hopefully create a community-led action. Thank you very much. So if you've got any questions.
Thank you very much. I hope you enjoyed both of these taster projects. I can guarantee that the other 3 are equally interesting and exciting. We're happy to take any questions, and my function hopefully is primarily to ping them on to one of the other 3. So.
Hi, thanks for really interesting research and presentations. My question was actually about the climate change work. So it was reminding me of some work that was done a few years ago at Lancaster looking at the impacts of flooding. And one of the key things they found around mental health was the effects on that were much longer term in terms of that kind of period of longer term recovery. So while that kind of immediate period was important, it was also that kind of the ongoing effects that might be kind of years or months or years. So I wondered if you were kind of looking at the spectrum of that kind of response phase to environmental crisis, or are you just focusing on a particular phase?
Can you hear me? Yeah, I think we would look at the whole spectrum to a degree, as much as we could. We're aware that, like, obviously flooding has got long-term impacts, and recovering from extreme events has got long-term impacts. So I think in some of the community-led action, there would be stuff about recovery. So it would be about supporting people long-term after floods or events or things like that. So I hope that answers your question.
Yes, Ashley.
Thanks, Frank. I wanted to ask about the project, the nighttime economy, and in any of the conversations, and maybe it's a little bit early on this, and I don't know, Lorna might have a perspective, but I wondered whether the advantages, the financial advantages of the nighttime economy are coming up in terms of the value of that to the city councils or the town councils or whatever, in terms of, you know, it's an important part of their maintaining their businesses and business rates and all of those aspects, as well as the social aspects of the town. So I wondered if anything from that had arisen from conversations.
So as a project team, we've certainly been talking about that, and we're keen to acknowledge that in some way. It is an important part of the story, given that public health colleagues talked to us about how difficult it is to raise the issues locally with people, others in local government who have other responsibilities, more focused on economic development. So it hasn't been central to our discussion with local government partners, and I'm also concerned about the ability of our framework to encompass positive health effects as well as negative health effects, but it will certainly be developed within an understanding of that, if that is sufficient to answer your question.
We all sometimes hear about alternatives in the nighttime economy that aren't necessarily unhealthy. And it's one of those where we find that it's an interesting idea and people talk about it, and there may be even a few examples, but how many examples and how widespread and have they been shown to work is an interesting one. But I think that idea of having a nighttime economy that isn't just there to get out your face, basically.
Just very briefly, I would just add to that, from a local authority perspective, there is definitely a tension in terms of economic priorities versus public health priorities, and I suppose that's why we're trying to really focus the narrative on kind of the public health priorities are everyone's priorities. They're not just the annoying public health team. It's us translating that into issues around community safety, around the cost of litter pickups and collections, very practical pressures for the local authority that actually are our biggest levers, and again, not necessarily articulating the health harms because that's longer term, but if we can make it on what are the things that actually councillors, cabinet, that put budgetary pressures on local authorities, that's when we can see opportunities for action in kind of joint ownership of those opportunities. Yeah.
Thank you. Is there time for one more question? Yeah, the last one.
Very, very quick. I don't know if it's quick or not, but it's on the climate change project, which looks really super. But I was just wondering, you mentioned health inequalities, and I wondered how you were conceptualising them. You know, what types of inequality are either you or the groups looking at? Because I appreciate it's a two-way thing. Thanks.
Sorry, I'm just thinking about it.
We can always chat afterwards.
It sounds like quite a big question, and maybe we should do that outside of this.
I'll catch you at coffee. We can have a nice chat.
Sounds good.
So thank you very much. I think we close this bit. Just to say, if you want to discuss any of the program with us, you can always talk or email Matt or me. But probably if you want a useful answer, it's better to talk to Mirela or Cheryl, who know all of this, or to Kat if it's to do with public involvement and engagement. Thank you.
Thank you very much to all our speakers this morning. It's been really interesting to have that whirlwind tour of all that's happening. We're going to take a break, slightly adjusting our time. We'll take 20 minutes, if that's okay. So be back for 11:50, I think, if that's okay, to start our next session. Don't forget, there are posters in the Hawks room, so please do go through and have a look at those as well. Thanks. See you later.